Warning. This will be talking about topics that might trigger you. Be aware before continuing on watching and listening to this episode. Thank you.
Hello, everyone. Welcome to another edition of Paolo's podcast. We're very excited today to have one of the top psychologists in South Florida, Dr. Kelly Everson, who is not only one of the top practitioners in Jupiter, Florida, she's also the owner of her practice. And she's going to be talking about her specialty and at the beginning, and also her practice, because she has a lot of practitioners that work underneath her, works with her, and she'll explain a little bit of their specialties, and then we'll get into different answers that you, the audience, have sent me. So I guess welcome, Dr. Everson. Thank you for joining us and sharing your time. First, I guess tell us a little bit about your practice and how it works and
Sure.
your specialty.
Sure. Thanks for having me, Paolo. Yeah, I'm a Florida licensed psychologist. I co-own Palm Beach Behavioral Health and Wellness. So we're a large behavioral health practice in Jupiter, Florida. At this point, I think we have 10 licensed psychologists on staff. We have had in the past, we've used speech pathologists, occupational therapists, massage therapists, acupuncture as well within our practice, as well as housed child and adolescent psychiatry services as well. So, you know, the goal of my practice in general is to kind of be a one-stop behavioral health wellness center. Right now, you know, we're doing that by offering individual, group, and family psychotherapy services. You know, pre-COVID, we were offering a little bit more recreation services as well to kind of go hand in hand with those. And we've offered some different workshops and everything as well. Right now, of course, you know, really focusing on the therapy services, especially because of COVID, that were majority, you know, for the majority, we're online, we're doing Zoom and FaceTimes and, you know, whatever else that works for our patients. But we are in the office, you know, part of the time as well. I do have 10 psychologists in total. So I personally clinically, I work for the most part with school-age children and teenagers and young adults. Most of them are high functioning on the autism spectrum for the most part. And so doing social skills and behavioral planning and a lot of cognitive behavioral therapy in general for that. I do a lot of parent training and parent coaching because I tend to think, you know, it's hard to work with kids and work with families without working with the larger, you know, unit that they're a part of. And so I work a lot with parents and the community and, you know, other physicians that are working with the children. But we have other psychologists that focus on, I have a trauma specialist. We have an anxiety clinic specific to that. So we have 2 psychologists that focus really specifically on anxiety and OCD and, you know, panic disorders as well. We have other psychologists that focus on just child behavioral mental health. So anxiety, depression. We do some sports psychology coaching, you know, in terms of that goes hand in hand with the cognitive behavioral work that many of my therapists do. We do some postpartum work as well for new moms as one of our focuses. And then we also do a lot of testing. So that's a big part of our practice overall, because I think, and you know, something we can obviously speak more to, but accurate diagnosis and treatment planning is really vital in this field. And so the testing comes into play when, you know, when you're looking at getting a really well-rounded picture of what a child or adult is dealing with and handling, and what are their challenges and what are their strengths. And so we do a lot of psychoeducational and psychological and neuropsychological testing as well.
I know, yeah, like you mentioned, you have your other practitioners with you, but do you handle, since you're working with the children, when you say children, what ages that go? Because I know, like, you see a pediatrician until a certain age, and then you go to a primary care doctor.
Sure.
So would a college student, is that considered still a child? Would they come in and see you? Or
So
would they go
there aren't as many Right. There aren't as many like hard set, like kind of age rules for what we do, especially as a clinician myself. I think that my strength tends to be kind of like the school age and teenage kind of adolescent years. But I have probably 6 or 7 young adults on my caseload right now because what they're struggling with happens to fall under my specialty. And so I do that. So I think with psychologists, one of the things when you're looking for a psychologist that you really, that I would highly recommend is that you want a specialist in some form. So you want, it's something that we take pride in at our practice in general. And I think it's really important when you're looking for a therapist overall or a psychologist is that you're getting someone who really knows the field of what you're dealing with, because someone who has a trauma is very drastically different from someone who's experiencing just behavioral concerns or school refusal or depression or something. There's some similarities, but there's a lot of differences in the way we treat those things, and so you really want somebody to specialize. I work with autism spectrum disorder oftentimes, and you don't want somebody treating you who doesn't specialize in that. Yeah, so I think it's really important. So it's not necessarily so much about age, but it's more so about finding the right fit in terms of the person, and knowing that they know, the latest research and what's going on in the field in which they specialize in.
Now, since our audience is nationwide and actually now we're expanding into Canada, is your practice kind of unique? So when you started this vision and you came out of college, I guess you did your residency and you started working for other practices, you built up your skill set, and then you said, hey, this illness or psychology itself or therapy is missing this. So then you design this custom-made program. Is it unique, pretty much, compared to what you like? I'm sure you go to seminars in the country.
Yeah, I mean, I don't know that exactly, I practice as a therapeutic orientation, I practice cognitive behavioral therapy for the most part, but with a few other things kind of added in. So that in and of itself is not necessarily unique, but what I do think is kind of unique and that I find in talking to a lot of other people is that idea is that people are really specialized. I really, I can't hit on that enough, because I really think that, especially, if you're a parent out there and you're, first of all, especially if your child is struggling, that's on a whole nother level, right? Than if it's us even, I think. But like when your child is struggling, I think it's really important, especially before you put some of your financial resources and your time and your emotional resources towards someone, that that they're really specialized. And so I think the uniqueness to me comes into play is that, we don't really house generalist clinicians. There are many clinicians, and there's a place for them. So don't get me wrong. I'm not saying that's necessarily just a negative thing, but I do think when you're calling in and you want to know that, you're when it's everything in your life, you want to know that the clinician you're talking to really, really knows how to treat that, right? Versus somebody who says, I see children all the way through geriatric, and I see, depression and anxiety and trauma and autism and marriage therapy and all those other things. There are clinicians who feel like they can see anything that comes through their door. I'm of the mindset that I would much rather specialize as much as I can, because then I know I'm giving my patients, the most tailored, up-to-date, treatment.
And it's hard. So how does someone go, like for me with my disease, it was, if I was looking for somebody who was covered under my insurance plan, which we discussed in our pre-interview, that a lot of the mental health is not covered by insurance. So that's an issue that we go into, that I will expand later into the topic. But so if you were to put in like layman's terms, and you're a mom, what should you expect if I bring my son or daughter in in for a session, if they're having anxiety, suicidal thoughts, or have it, something's been brought to their attention, and who would that usually be brought to? Is that brought to attention by them observing, or is it usually in your situation, it's like a guidance counselor or a teacher or something like that? Does it come from a variety of ways of signs?
Yeah. So Yeah, definitely. And especially when you're working with kids, especially it comes from a variety of different places because, and a lot of times it does come from the school in some sort because kids do spend the majority of their time in schools. And so if we can have, adequate, good kind of screening ability in the school, then we can get at, the right kids that need services. We've all heard obviously the tragedies and things that have happened in our schools in the last 10, 20 years, unfortunately, and more. And a lot of times it's because the right kids are not identified as being at risk for things. And oftentimes many of us who work in the field feel that could these things have been prevented with adequate mental health care. The number one treatment in general for across the board for any mental health concern is regular, adequate mental health care, specifically psychotherapy. That is the number one treatment across the board. And so when we don't identify the right people quick enough, that then we have these big tragedies that happen. So the schools can be really vital for that. But being in private practice, I get lots of referrals from psychiatrists, from other pediatricians, from primary care doctors if they're adults, from other physicians, and then also people in the we're in the Google generation now, right? Like everything is on Google. And so thankfully people who want help and are really looking for it at this point self-refer, thankfully, and they're on Google and they find your picture, they find a review, or they may find a link to a podcast like this or something like that, and reach out for help because they felt like, okay, this is making me do it. So it's things like all the outreach that you do, and it's all that kind of stuff too. It's not just the clinicians, I think. And then once they get into the office, then it's on the clinician. And at that point, it's all about fit with your clinician. So you ask me, what do you look for, in a therapist, or what do you look for in a psychologist? And the number one thing you look for is fit. So, and that pretty quickly and pretty naturally. How do you feel when you walk into that office? First of all, the environment that the office is in is really important. But then once you're back into an office with somebody, how do you feel? How do they make you feel? Do they make you feel shameful, or worse because of what you're talking about, or do they make you feel supported and give you encouragement for being here and and asking for help? I think that sets the tone. And that, even more than probably any actual clinical intervention that I could do, I think the rapport building and the fit with my clients is probably the most important part of our relationship. So after that, people feel more comfortable telling me if they're, contemplating suicide, or, if they're really struggling, or if they need help in another area of their life, or, for whatever else they may be struggling with.
Yeah. Do you recommend that? Is it a case by case situation with the parents, I guess at a certain age, sitting in with their son or daughter in the session? Or like, obviously I'm an adult, so when I go in with my psychologist, this is my time, and I know
Yeah.
it's a safe
Yeah.
place, and also it takes it away. So how does that work with the child, and what can they expect? Should they just trust it with the psychologist, or sit in there and actually knowing that the son or daughter is telling the psychologist the truth,
Right.
so you get the right information and can correct it, right?
Sure. So that's a fine line that continues on throughout your relationship with a client, frankly, when you're working with kids, especially. So in general, when we do intakes at our office, if it's an adult, then they come on their own, right? And you just come back and the hour is yours, and we start building rapport right away. If it's a child, oftentimes, I'll greet the child, but really I need to speak to the parents for a bit, because I need to collect some history and I need to kind of go from there. I don't typically do that with a child in the room. I tend to find children they get pretty uncomfortable, and parents also have, don't speak freely, of course, when their kid is sitting in the same couch with them, or they're sitting on the floor, right? And so I typically will start with the parents, and then after I'm kind of collected some history and I kind of know the direction that the parents are hoping to go in, then I can get to know the kid. And I like to do that one-on-one, because I think, in front of parents, kids act drastically different in front of their parents than they do without them, of course. And the reason that parents are bringing their kids to therapy is that they want their child to have a safe place where they can talk about things without them, honestly. Like that is what they're looking for, right? And so, letting the kid have that space. The older kids, I think it's also really important to talk about confidentiality versus privacy. So as
Explain it too.
yeah. So as you get closer towards being an adult, right? Like when you're in your teenage years, it's important that teenagers have some privacy in the therapy session, meaning they need to understand that the therapist is not going to go to their parents and tell them every single thing that they said in therapy. Otherwise, a teenager, like you said, why would a teenager trust a therapist if they think that the therapist is telling their parents every single thing they're saying? It defeats the purpose. So I talk to my kids about confidentiality versus privacy. So when you're a minor legally, there really truly isn't confidentiality. If your parents, push to know anything specific, then the parent is the guardian, or whoever's the guardian. I'm assuming it's a parent, obviously, but there's a lot of different family structures, but whoever is that, is the guardian, and they do get to make the decisions and all that. So confidentiality, you come into my office and a child tells me that they're contemplating suicide, then I'm legally bound to bring the parents in and talk to the parents, because there's a risk of safety, right? If a child talks to me about risk to self or others, I'm really like, I'm going tomorrow and I'm going to do this to so and so, and they're, and they have a plan, and they're set to do it. Then I'm going to say to the child, listen, you and I talked about this when we met. We got to bring your mom in here. We got to bring your dad in. We got to talk about this all together. They have to know about this. And so I try to do it so that, everybody's still on the up and up, like there's still no kind of secrets per se, but they have to know that my goal, and my responsibility is to keep them safe. As a child, that is my goal. And so they don't have true confidentiality in terms of if I feel the need to tell their parents something, then I need to be able to do that. And they have, as a minor. But on the flip side, typically, do I need to tell the parents everything? No, because I want them to have a safe place in my office.
Do you explain to them that this type of therapy is not a quick fix, it's a process? And do they know? Because one of the questions that came to our table is that my son or daughter, I think, needs support and needs help, but they don't want to get the help. They don't want to get in. So what would you recommend to a parent or even a patient, an adult, that if I had my own sister as a grown adult is not getting the right help that I think that she should need, or son or daughter, if I had one, how would you handle it to get them motivated to go in? And because we, as an outside observer, we could see different problems that they have that they might not be seeing and looking at the mirror correctly. So what advice would you give somebody to seek out, to get help and give it a shot and say, look, it can't hurt?
Mm-hmm. So I'll tell you this, the first thing it goes back to the rapport building 100%, first of all. So, I have a percentage of kids that come to our waiting room, and you can see them in the waiting room. They're slumped over in the chair. They're not there willingly. Mom and dad are filling out paperwork, and the kid's got headphones on or whatever, and is like, got the hood over their head and everything. They're not there willingly. And, it goes back to rapport. So, the very first session when I'm building rapport and getting to know a kid, we're probably not going to delve into his deepest, darkest secrets. We're probably not going to delve into even his panic attacks potentially, because I want it. Why would I assume that somebody, just because they're magically in my office, that they're ready to be vulnerable immediately, right? And even as an adult, that's a big assumption to make, that somebody's willing to just lay it all out there before they trust who they're talking to. And so, that's earned a little bit. And so for some kids, it takes a couple of sessions at least to build rapport. Parents are like, my kid told me you talked about video games for half the session. And I'm like, well, I did. I mean, that's honest, but not just for the heck of it. Like, I didn't really want to talk about video games for 20 minutes, but Your kid also then came in the next session and trusted me and told me a whole bunch of other things because I showed some interest in what he cares about, right? And so it goes back to rapport. And so we do talk about, like, it isn't a quick fix. There are a few things in therapy that are a little bit faster fixes. If somebody is super willing and ready to work on things, we can put things like coping skills in place. And, you can work on some things like exposure therapy for phobias, for example, or something that do tend to be a little bit shorter. You can actually do that in a certain number of sessions. On the flip side, and I don't specifically advertise myself as somebody who sees clients for years and years and years and years and years, and that's not typically the modality of cognitive behavioral therapy. But I have clients that have come and gone and taken a break, and they come back and stuff because they feel comfortable with me. My longest client at this point is 10 years. And so have I seen them consistently for 10 years? No, for sure. But they feel comfortable with me and they think of me as their psychologist. And so, it kind of ebbs and flows a little bit. But once you have a relationship with somebody, then thankfully, as things come up in real life and things happen, they have somebody trusted that they can come back to. And I think all of it goes back to building rapport and having that, like, the core relationship with your client before you expect them to do the really hard work.
It's also too, you have to be careful as a professional. Is like, look at my situation, is that it just came out of the blue and I was on a downward spiral, and I think I told you I was ready to commit suicide because of my disease, and thankfully I connected. And I've seen great psychologists in the past, but there was just a strictly something happened where we connected. And now with the COVID, my doctor has not been as accessible because he's dealing with his own personal issues.
Sure.
So I felt, since this has been around for a while now, and I found myself, I call it checks and balances to keep myself what's real. I found myself falling, where I'm a very independent, strong man, and I think, and I'm very stubborn, being codependent on my doctor. And do you find that where it's like, hey, especially because I'm so compassionate and helping others, is that, like, I'll ask him how he's doing with his family, and he'll discard he said, Paolo, it's not about me, it's about you. Do you have to, is that a rule of thumb with a practitioner? Like, it's not you sharing your life, it's about you.
Yeah, I mean, so the word for that is self-disclosure. So how much each practitioner, each therapist talks about themselves differs for each therapist. Everybody has a different comfort zone, and everybody, was taught differently when they went to school for this. Everybody was taught a little differently. In the beginning of your career, I think especially you're taught to keep pretty strict boundaries if at all possible, because you're learning still and you're fairly new to it. And, you want to be careful with how much information you give out in certain jobs, and different populations. You may or may not give out much information, about yourself, because then that could put your family at risk, or something like that. As a clinician myself at this point, I don't do a ton of self-disclosure, but I also have had a lot of clients who, for example, knew that I was pregnant and then had a baby. So you can't hide that, right? And so they know. And the other side of it is that, as somebody who's been practicing in the same area for 10 years and having clients that have stuck with me, for 10 years, I'm a part of their lives, and 100% to a certain extent, they're a part of mine, and part of, the therapeutic process is very one-sided. It's meant to be one-sided. They're not my therapist in any form, but at the same time, we have a relationship, and I value that relationship as well. And, because we've built that relationship, they genuinely care, about my son, for example, they'll ask about it and stuff. And I think, as a therapist or as a psychologist, as a clinician at all, you kind of just have to make a decision in terms of how much you're willing to self-disclose and where you draw the line, in terms of what you can talk about. Because, I never would want to self-disclose and then have my client go home and worry about something that I said. And that's where the line is drawn. And so we always want, when we're taught about self-disclosure, we're always to say, always make sure when you're disclosing something about yourself that it has a purpose. So I'm just not going to talk freely about myself just because I want to talk about myself. It has to serve a purpose in our relationship or in our therapy session.
That's actually helpful for me, because I wonder, because I got so close and this man has just done so much for me. And I feel, all right, when there's times, and also too, since he's a vice president or a board of directors of a not-for-profit, there is times when, obviously, when I'm in the session, that I only talk about my issues and my problems. But then when there's times that he goes in, I want to know how's he feeling, if his family's okay. And I didn't know if it was an ethics thing. When I mentioned by the first session, and you might have a different technique, or if there's a rule of ethics that I didn't really care, but I was worried a little bit about the word, the parents might not know Baker acting. When I went in and I said, listen, to be honest, I'm here. I don't want to hurt anybody, but I have a terminal brain disease. And I said, that's my main issue, is that the collateral damage that suicide happens. I'm not going to do it today. I don't have a plan, but I know as my brain starts to die off, there's concerns that I have. Like if I was to jump off a bridge with my luck, I wouldn't die. I'd break all my legs and still be alive and make my situation even worse. So obviously I can't get that advice from a friend or someone else. I need that from a professional. But I was afraid to actually bring that up because that's going to raise a flag with the psychologist, right? And you said they have to protect you, and it's your responsibility to talk to somebody else if they're going to act out. So is that separate from dealing with an adult than it is from dealing with the child? How do we have that situation so they feel comfortable?
Right. I mean, like, so with all of this, there's obviously a very fine line, right? Like, I want to maintain my relationship with you as my patient, if you were, right? Like, I want a relationship, and I don't want to break your trust, right? And I want you to come in and tell me what's on your mind and be totally honest and stuff as well. At the same time, legally, it is my responsibility to do my very best to keep you safe. And if you tell me, and you are specific that say, I have a plan for this, this is what I'm going to do, and this is when I'm going to do it. And, and I'm concerned as a clinician, I make the judgment call that I'm concerned about your safety. I have the clinical responsibility, to Baker Act. I do. With minors, I mean, it's complicated with minors and with adults. Technically, it's complicated. And let me be clear, our system is broken. And I think, everybody would agree with that. It's a broken system, 100%. I know we'll hit on it in a bit, but the people who need mental health care the most oftentimes don't get it. And then also the people who need the most help and higher levels of care don't get it, can't afford it, can't get to it, don't ask for help because they're worried about being hospitalized, all these different things. It's a broken system because, I'll speak to our local system as well. We live in a very populated, Palm Beach County is a very wealthy, populated area, and we have very few services for Baker Acts, as well. And many people don't want to go to the Baker Act hospital, or they know what's going to happen, or they've heard stories, or whatever it is. Or, and so for a variety of reasons, they're not truthful then. And they may or may not even bring it up to their therapist or something as well, because they're afraid of what could potentially happen. If you're a parent, people are fearful of losing their kids, which, and so like the system, we're not catching the right people, and we're not getting the right people enough help when they need them. And obviously there's no easy fix to our system. And many of us are involved in, other non-for-profits and trying to figure out, how to help with some of these things, but there's no quick, easy fix for this. But it's our system is broken when it comes to crisis care, especially.
You know what? Let's take 2 second breaks and come back to our second chapter. They'll be posted up. And on that, we'll be talking about, we'll expand a little bit and let the parents know about what Baker acting is and what the pros and cons of it. And also too, I know what cognitive therapy is, but I also too want to expand on that issue. So let's just get another 2 seconds so you could have a drink. Thank you.
Thank you for watching Paolo's podcast. This concludes Chapter 1 with Dr. Kelly Everson. Chapter 2 will be posted next week, December 23rd at 11 a.m. Eastern Standard Time. We strongly encourage you to check out our company website, Concussions, Pain, Mental Health Awareness at cpmha.com. where you can access free resources for coping skills and strategies you may find useful. We also encourage viewers to consider donating to our nonprofit, which helps keeps our mission alive, going strong, and help fund future projects. You can donate through our website at, again, cpmha.com. And remember to like, subscribe, and hit the notification bell in order to receive notifications each time we post a new podcast. Thank you.